Hi, welcome to our discussion on consumerism. As we saw in the last module, or in the previous module about revenue cycle, really the patient is touched when they come into the facility through the admissions process, and then afterwards, the billing is the last thing they see from the healthcare facility. So having that life cycle going from the admissions process through to the clinical care, whether it's a doctor visit or an ambulatory procedure or through a hospital stay, to when the billing comes, really, there's a lot of things that happen with the patient, and the patient really has a lot to say about their healthcare, a lot more certainly today than they ever did before. And one of the pushes of meaningful use was that patient portal, and we're trying to shift people away from the I'm going to the doctor and I get things done to me and then I leave and somebody pays for it, to the being more cognizant of what the charges actually are. And we already talked about how CMS is requiring the charge master to be published so that people know what their billable charges are. I was in a hospital probably 10, 12 years ago, and one of the difficult things I had was getting the hospital bill. And they were certainly willing to give me a bill for a couple $1,000s. But when I asked exactly what the charges were for, that was a challenge to get that out of the hospital. And part of it is because these reimbursement rates are negotiated with the different insurance carriers. So it's really kind of hard to figure out what the cost is if the Tylenol is $20 for a specific Tylenol pill, or if it was negotiated down through one insurance company to $10, or if the private pay is $30, whereas CMS is reimbursing $2. So how much does that actually cost? Not only that, but how much of that is wrapped up into a facility charge versus being charged individually. So from a consumer standpoint, we had no visibility as to what happened. When I bring the car in to be serviced, they go through, they do a checkup, just like you would do at a physician, and they come back with a list of things that they recommend or suggest for me to do. And I have an itemized list of how much that costs, whether I want to replace the air filter, if I want to replace the windshield wipers, certainly the oil change, tire rotation, but I have a set amount of dollars that each of those services cost, and I can pick and choose upon which ones are most important to me. We haven't had that in healthcare. As a matter of fact, going in for a simple colonoscopy, you have no clue what that's going to cost. People can't tell you. So you get a referral to a gastroenterologist to do a colonoscopy, and you say, how much is that going to cost? They don't know, because the fee for the physician may be different from the facility. Maybe you went to a different facility that has a different fee. Maybe it's out of network, which means that you have a higher cost, because, especially out of pocket, because there is no negotiated rate for it. So there's a lot of variables that are involved in healthcare that are not involved in other aspects of our life. Even if a law firm, you call up an attorney, how much does X cost? And even though they hide some of the charges, or it's difficult to tell some of the charges, at least they can give you an hourly bill rate, as well as sometimes a flat rate for a divorce, or for a bankruptcy, or for some other type of service. Don't have that in healthcare. So we're trying to get more transparent because the patient needs to see that. Part of the reason they need to see that is because of the changes in insurance. Gone are the days of the $2 million lifetime maximum and the segregation by actuaries of patients depending upon their morbidities. Now we have the more universal care. And we'll talk a little bit about how some of that's changed through some executive orders and legislation over the past year or so. But patients now have the ability to go out and find their insurance. Now, they're supposed to use the insurance for their employer, if they're a W-2 employer, but if they're not, or if their employer does not offer health insurance, then they have to go out into the marketplace. The place that people have been able to go is to healthcare.gov, Healthcare Market Exchange, and those are ACA approved policies. And what those are, as we learned earlier in the course, is that the ACA has prescribed a certain minimum benefit for each of these policies that the policy has to have in order to be ACA approved to then qualify for tax credits. Well, since since we no longer have the individual mandate in as much, and it will be changing for the taxes over the next couple of years, there have been a increase in the number of policies that are available that are more that traditional $2 million 1-year policy that they will look at your past medical history and approve or deny you based upon that. And then if you get approved, then it's based upon, age, gender, smoking, some other, demographics to come up with a policy dollar amount. Regardless of whether you have an ACA approved policy, an employer policy, or you get one on the private market, all health insurance policies have the same basic setup. And that is that there is a premium that you pay, that there is a deductible that is counted towards your healthcare expenses, and then there's what's called a stop loss. There's also co-insurance, but the co-insurance typically counts towards your deductible, but always counts towards your stop loss. So let's say, for example, you get a policy that's $200 a month because you're relatively young and pretty healthy, and you have a $10,000 maximum out of pocket and a $1,000 deductible. And the way the policy is written is that you pay for everything up to the first $1,000, that's your deductible, and then the policy will pay 80-20 after that, 80% of the charges, and you pay 20% of the charges up to a maximum of $10,000. So no matter what happens to you, that the most you're going to have to pay is going to be $10,000, and the policy will pick up. Now, if it's not an ACA policy, an ACA approved policy, then that maximum is going to be probably $2 million. Then anything after that is going to be on you. Now, a lengthy hospital stay can exceed $2,000, especially if you're in the ICU and you have multiple issues going on. So that's one of the problems. The other problem is that after a year of having this policy, or when the policy period expires, they don't have to renew you. With the ACA approved policy, they do have to renew you, and they can't charge you more because you've been in the hospital. So that's one of the benefits of having an ACA policy, is that there's no lifetime maximum and they can't deny you. As long as you're paying your premiums, you're good and you're covered. So we talked a little bit about deductibles, and we talked about the stop loss, the maximum out of pocket that you're going to have to pay. And when you're looking for healthcare insurance, the other variable that you have to consider is also going to be the physician and medications to a degree as well, but the physician that accepts the insurance. It doesn't matter if the insurance is dirt cheap and has remarkable coverage if no provider in your area accepts it. You're not going to be driving an hour and a half, 2 hours to get, to a primary care doc or to a facility to receive coverage. So it's important that it's also something that's around you. We mentioned earlier that the insurance and the healthcare systems kind of have a relationship where the insurance companies don't want to pay more than they have to, but they have to have hospitals because otherwise patients won't take them. They have to have physicians, otherwise patients won't take them. But at the same time, hospitals need to accept insurance to be able to get patients. And that really comes into the negotiation process. So we try to, as healthcare administrators, we try to make sure that we're covering our bacon and making sure that we have to have a profit. It's like any business, you must make a profit. But at the same time, you also want to have access to those policyholders that are in that area. The insurance company wants to have policyholders in that area. So it's kind of a double-edged sword, and it's kind of a dance that they do. Now, I mentioned earlier that I felt that the hospital's true customer was really the physician. And here's why. As a patient, one of the things I'm looking for is in a healthcare insurance is obviously I'm going to be looking at the deductibles and the premium payments every month that I'm expected to pay. But I also want to make sure that my physician is covered under this plan. Otherwise, I have to switch physicians. And that's just a pain because, well, first of all, it's an administrative pain. Second of all, it requires you to get to know a brand new provider. That provider has privileges at different facilities. Whether it's ambulatory, whether it's hospital, they have different privileges at these different facilities. So if you have to go into the hospital, you would like to have your physician follow you. Well, if the hospital doesn't take your insurance, and a physician doesn't go there, then you're not going to that hospital. Most of the time, people don't really care what hospital they're going to as long as they have the physician that they like, or their preferred physician. But they may have a preferred hospital, but the bottom line is that if I'm going to spend $10,000 to go to the hospital I want to versus $1,000 to go to one I may not want to, I'm going to follow the money. So whatever costs me the least, that I get the best care is really where I'm going. And hospitals recognize that. So they do cater to physicians to bring patients to their facility. I would love to just say, I'm going to X hospital because it's the best in cardiovascular surgery, but if my plan doesn't cover it, I'm not going to that hospital because I'm not spending all that money out of pocket. So they do cater to the physician to a degree. When you hear new facilities being opened, most of the time what you're hearing about is the innovative Da Vinci robots, or you're hearing about the awesome orthopedics or the cardiovascular. You're hearing about some of these services that are being offered, even maternity, OBGYN, because of the fact that when you offer these types of services to the community, really what you're saying to the doctor is, come to our facility, bring your patients to our facility because we have the latest and greatest technology. Now, typically these areas that they have the latest and greatest technology or the newest facilities are the high profit centers. You're not hearing people go, come to our brand new ICU or our brand new emergency room. They might say that their emergency room is fast, or but typically the emergency room, you don't really have a choice. You're going to the closest one, or the EMS is taking you to the closest one. Emergency rooms and ICUs are not profit centers. What's a profit center is the orthopedics. And that's one of the reasons Ohio specifically has had such an issue with these freestanding ambulatory centers, is because you go in there and you get your hip replaced or your knee replaced, you're there for a couple days, or maybe it's even outpatient, colonoscopy or something like that, and you get out of there. The hospital, the freestanding ambulatory center, then closes down for the night. They then open up the next morning. What happens if something goes wrong? Well, usually an ambulance is called and you're taken to a tertiary care center where you're then put into one of their revenue loss centers, an ICU, through the ER. So hospitals don't like that because these freestanding ambulatory centers are scraping off their profitable business and then leaving them with, if mistakes happen, as a line of defense and really that they're using the hospital resources without having that balance. So it's really interesting how these things work. But as a patient, you're sitting there going, I want to spend the least amount possible. I mean, that's the economy that we live in. I'm responsible for my payments. I'm responsible for my deductible. I want to go to my doctor, and my doctor wants to go to the best facilities that are available where he makes the most or she makes the most amount of money and the highest profitability. And a lot of these are ambulatory centers. So, one of the articles I think I had you read was about healthcare marketing and how the large facilities such as an Ohio Health or some of the, Kaiser Permanente, that people aren't really swayed to go into a facility based upon that brand name. That a hospital or a healthcare organization being purchased by another one or changing their name with their branding really doesn't influence the consumer, you and I, as much as the hospitals would hope. So again, where do your marketing dollars go? Even though you're marketing to your community, you're really also marketing to the doctors and also spending that money marketing the new facilities to have doctors want to come there. So, the CEOs, like I said, I believe that the doctors really are the customers in this situation, and because they drive the patient volume to the hospitals. Another trend we're seeing is consumer wearables. And before we really get into consumer wearables, I remember back in the, I would say the early 80s, my grandmother had a friend of hers who was carrying around this large portable device that had a strap on it. And what it was is it was a mobile EKG. She'd had some chest pains, so that they were looking at, through a period of time, 8 to 10 hours, of what that, EKG looked like. And she would go in, every couple days and have the information downloaded from this device that she was wearing, and then they would be able to pull it up and interpret it. Well, we still have devices available that patients can use at home, whether it's a blood pressure cuff, manometer, or if it's the scale, obviously AccuCheck machines for diabetes, checking for blood sugar level, as well as portable EKGs. There are things that are out there that consumers can use, that hospitals can put. We have at-home sleep studies actually as well. For checking to see if somebody's snoring or if their breathing stops. So those sleep apnea type things, those are all things that have come about over the years and have moved things out of the hospital and into a more patient-friendly environment, their home. But we also have the risk of, and some of this stuff is connected now instead of having a download with with a cable. Some of this is linked wirelessly through the internet. So it goes up to the cloud where it's pulled down by the clinicians to then evaluate the patient. We also have some other telemedicine, if you will, where we have virtual ICUs, where you have one physician in a centralized location that it's surrounded by a bank of visual monitors of cameras looking at the patient, as well as monitors of vital signs and functions, what have you, and the ability to pull up everything from the patient history to their to the medications that they're using, lab results, studies as well. And then you'd have the nurse that would be on the other end taking care of the patient in the physical location while they were being directed by the physician in a remote location. One physician might be able to handle 5 or 6 rural ICUs that have anywhere from 2 to 7 beds. So they're basically just on call all through the night. So those types of virtual environments also exist. And looking at that information being uploaded, one of the primary concerns, of course, is security, cybersecurity. And there has been an increase in the phishing or the hacking of consumer devices, and specifically not just the medical equipment that are given by the clinician or that they pick up or is mailed out to them, but also some of the wearables. Now, we see more and more wearables, ever since like the Apple Watch and some of the pedometers back a few years ago. Some will actually take your heart rate. Well, now they're actually not just doing your heart rate, but actually being able to do some sort of a modified EKG. Now, full EKG requires at least 4 leads. Of course, there's also, many more than that. But, just to be on telemetry only really requires 4 leads. But I don't know how you're going to get that off of a watch. But you can potentially put something around your chest that is then wirelessly linked to your phone or to your watch that would be a little bit more accurate. As technology improves, the accuracy improves, the devices become smaller and more portable, but that also introduces, the cybersecurity threats of having that information uploaded. It to me is really awesome, looking at, Best Buy, even for the holidays. Not only can you get a watch, but you can get the fall monitoring, whereas if somebody decelerates from a plane to another plane, that's considered a quote-unquote fall, and that information is then put into a system where it goes to a remote monitoring source like an ADT, or potentially to you, or if this is an assisted living facility, maybe it goes to the head nurse's desk. So those are things that are available. Monitoring devices for falls, I thought was very interesting. There's also wearables that you can have for patients that are code silvers, as they call them down here in Florida, where you have an Alzheimer's patient who got in a car and left and you have no idea where they are. Or you have a patient that just wanders and it's very difficult to keep track of them. Well, we have RFID chips, maybe that, around a wearable such as a bracelet or a necklace that would be able to track them. It's just really interesting to have, this wealth of information as a consumer, the ability to see what my heart rate is, medication reminders on the phone or on a device. We have Amazon that's taking over some of their computing power in a cloud-based situation to comb through patient records and then and consumer buying habits, and then push that data out where it can be usable to people who are advertising or targeting these people. As consumers, we have more power than ever to choose our health care, to choose how we spend our money. I specifically look for plans that pay for at least the first 2 doctor's visits because I go twice a year. Medications are not as important to me because I might be on a $3 or $4 blood pressure pill that's a generic. But you might have a patient that has, or have a consumer who has children who might be on ADD medication, and maybe they're on Vyvanse or they're on some other non-generic medication that costs quite a bit. So really being able to judge of how much do I want to spend on a month, how much do I want my deductible to be, if I break my arm, how much is it going to cost, how much is it going to cost to manage my diabetes or to have a pregnancy. Those costs are much more upfront than they've ever been before, and it allows the consumer and empowers the consumer to make decisions like they've never been able to make before. The biggest issue that healthcare facilities have as they push out patient portals is having customers or consumers take ownership of their information, take ownership of their healthcare. From a financial perspective, it seems relatively easy because they have to choose through these plans and make payments on them and then choose when to go to the doctors and be cognizant of how much you're spending. But on the back end of it, the test results, going into the patient portal, filling out the requisition forms, part of the admissions process, scheduling the appointment. The younger, more computer literate patients tend to do better with these patient portals, with scheduling as well as paying their bill, than older people do. But at the same time, we have to take care of the whole patient population. And whether you're a brand new baby, whether you're an adolescent or teen going in for some routine procedure, whether you're a young adult who's fairly healthy that just has a broken leg because of a basketball injury, a pickup basketball game injury, or something like that, all the way up into middle age when you have a family to consider, and now I have children, and I have to worry about the care for them and any medications that they might need, all the way into our older years where we are typically trying to take care of our health better, or monitoring things better, and we're going through. We have decisions now. We have the ability to find out what our lab results are without having to ask for them or pay $1 a sheet to have it printed off to us. We have the ability to make the request to have physicians transfer records from one provider to another. And we have the opportunity, ultimately, with healthcare IT, to make the best decisions that we've ever been able to make in our lives.